All right, good evening, everybody. Just giving everyone a few more moments just to join. We'll start promptly in the next minute or so. All right, lovely. As the waiting room continues to fill up, it only makes sense that we begin with a few introductions. It's a great pleasure to have you all with us. Thank you very much to our existing members who've taken time on this evening to learn a little bit more about the interesting developments in this all-important field. And for those of us joining us for the first time, welcome to one of the events by the Society of Interventional Practitioners South Africa, or SIPSA. We're an organization that promotes the legitimate, safe, effective, and ethical use of psychedelic treatments in South Africa. Psychedelics, both classical and non-classical, as we'll talk about this evening, like ketamine, are really the next frontier of treatment for people with mental health disorders, neurological disorders, and chronic pain. And we're really excited to be able to provide a basis and framework for the safe, evidence-based administration of these medications. And in light of that very aim, tonight we have two exceptionally interesting topics, both of which have a very strong ethical slant. We're going to allow our presenters to present one after the other, and at the end, we'll be fielding questions. Just a reminder to those joining, if you haven't already muted your microphones, please remember to do so for the duration of the talks. And once both of our presenters have finished their presentations, we'll open the floor to questions and discussion. The first of our presenters is none other than our Society's Secretary, Dr. Catherine Knight. She's a specialist anesthesiologist who attained her specialty at the University of Witwatersrand in Johannesburg in 2011. She's currently working at the Knysna Life and Advanced Private Hospitals, providing anesthesia for a variety of surgical specialities. She has a special interest in opioid-free anesthesia and ketamine for mental health and chronic pain disorders. She established Ketafuse, an ketamine infusion clinic in Knysna Central, and she is also a member of the South African Society of Anaesthesiologists and of the Sedation Practitioners of South Africa. She, in her personal capacity, is married to Ben, a chemical engineer, and they have two lovely children, two lovely dogs, and two lovely cats together. So quite a big family. This evening, Catherine will be taking us through the administration guidelines for SIPSA on ketamine, and it's really presenting a South African perspective on ethical and safe practice using ketamine for mental health and chronic pain. So, Kath, please take it away, and thereafter we'll introduce Leisha once you're done.
Thank you so much, Anthony, for that wonderful introduction. I decided I'm going to present from a tropical island today. Hope you guys don't mind. I'm just going to share my screen. Here we go. Okay. Can everybody see that?
Looks good, yes.
Great. Okay. There we go. Hope you can see the whole screen, but I'll be telling you all about it. All right. Okay, so the ketamine administration guidelines. Thanks, Anthony, for the introduction. I'm an anaesthetist working in Knysna, and my disclosure is that I also run a little ketamine clinic in the heart of Knysna, and providing a service of ketamine infusions to patients who have mental health disorders and chronic pain disorders, with amazing results. They've done really well. Okay, so I just would like to first show you. So the guidelines that we have, it's sort of been more than a year in progress, and it's been a collaboration of the work among the mostly the exco members of SIPSA. And we've consulted widely in terms of the literature. And I'm just going to show you the list of the references that are quoted in the guidelines. Um, and it's about 40 references that we have. Articles, guidelines, SASA practice guidelines of 2022. You can see down there at number 3. Oh, actually, sorry. The screen is, it didn't format well. And also we obviously have consulted the SOSPOSA sedation guidelines. SOSPOSA is the Sedation Society of South Africa, of which I'm also a member. Yeah, so many articles, and the whole purpose of the guidelines is that they are safe, practical, and evidence-based. All right. So let's talk about ketamine, because these are the ketamine administration guidelines. So we all know this, but I'll give us a very brief history. Ketamine is a drug used for anesthesia and sedation during medical procedures. It was first created in 1962 by Professor Calvin Stevens. It's FDA approved and listed on the World Health Organization Essential Medicines list. It is widely used in children, adults, and animals for anesthesia and sedation. Ketamine creates a unique state called dissociative anesthesia. It is considered a safe drug in that it stimulates cardiorespiratory activity, making it extremely useful in resource-constrained or unmonitored situations, such as on the battlefield for wounded soldiers. In South Africa, ketamine is approved for anesthesia and sedation, but its use for mental health disorders is considered off-label, meaning it's not officially authorized for these conditions. However, many drugs are used off-label, and this is widely accepted in the medical field. I won't go into the details with that. Now, just to tell you a little bit about SIPSA. Hold on a second. Can you see my screen a little bit better now? Okay, so let me tell you about the Society of Sedation the Society of Interventional Practitioners South Africa. There's a photo from our conference that we had in May in Sandton, and that is our exco, except for one person. Mike Henry is missing. On the left, we have Dr. Thasigan Moodley, who is a DA anesthetist, Dr. Anthony Townsend, a clinical psychologist, Dr. Sunthiran Pillay, psychiatrist, Philippa Scauno, who's a counseling psychologist in Cape Town. We have Dr. Carl Buster, psychiatrist in Cape Town, and me, a specialist anesthesiologist in Knysna. Our society was established in April last year as a non-profit organization to represent professionals in the field of ketamine therapy. And members include psychiatrists, and anesthesiologists, GPs, psychologists, social workers, nurses, and other health professionals. And we as SIPSA advocate for a multidisciplinary approach to ketamine use in mental health and chronic pain, with a focus on patient safety, evidence-based practices, and access to care. The society also emphasizes interprofessional collaboration and aims to prevent misuse of ketamine. And we are also members of ASKP3, you can see the icon on the side, which is the American Society of Ketamine Physicians, Practitioners, and Psychotherapists. All right. Next slide. So, guiding principles for developing these guidelines. We followed these principles to ensure safety and efficacy. Evidence-based treatment protocols individualized to each patient, appropriate practitioner administering the ketamine, appropriate setting in terms of monitoring and emergency equipment, drugs and consumables, and access to services in case of an emergency. Patient, physician, and drug factors. So, patient factors, chronic pain and mental health conditions often overlap, and social factors may affect treatment. SIPSA is committed to ensuring access to care for all patients, regardless of their location or socioeconomic status. Physician or practitioner factors. There's a shortage of specialist psychiatrists in South Africa, and GPs may often be the only providers available. SIPSA values the role of GPs and encourages collaboration and competency building to provide safe and effective care. And then drug factors. Ketamine can be administered through different routes: intravenous, intramuscular, subcutaneous, and sublingual. Each route has different benefits and risks, and it depends on the patient's needs and their treatment plan as to what route of administration is going to be chosen for their treatment. We also aim to prevent misuse of the drug by restricting access to this treatment in the clinical or room setting only. And moving on. What level of training is required by the medical doctor who is administering ketamine? So it's recommended that only doctors who have received training in advanced life support techniques be authorized to administer ketamine. And I actually recently went back to the SASA guidelines on this, and they also say in their guideline document that the doctor must, at minimum, have an advanced life support qualification. So in decreasing order of specialization would be a specialist anesthesiologist, then a DA anesthetist or a GP anesthetist, or a medical doctor who's completed a course in sedation training as provided by SOSPOSA. And then at minimum, a medical doctor who has an up-to-date advanced cardiac life support qualification, like many of our... I see that my camera has decided to turn off. Sorry about that. Oh dear. This thing is quite, it's tricky sometimes. Sorry, guys, and I don't even know how to turn it back on. So I'm just going to talk. Apologize for that.
No problem, Kath. We can still see your slides.
Okay, great. Okay. So, what about a nurse who's monitoring the patient who's receiving ketamine? So a trained nurse may monitor the patient if the doctor is close at hand. The supervising doctor has a duty to check up on the patient and nurse at regular intervals if she or he himself is not monitoring the patient. The nurse may be an RN, EN, or ENA and must be registered with the South African Nursing Council. They must have received training in advanced life support techniques with an up-to-date BLS qualification. They must also have been trained by the doctor who they're assisting, as laid out in this document in terms of process, what to expect, and when to call the doctor in case of emergency. Just a nurse pitching up to help in a ketamine clinic needs to actually be taken through the process and the steps by the doctor that they're actually working with. And we believe that no non-medically trained person should be allowed to administer ketamine. Some ethics and good practice: respect the rights of the patient at all times, obtain informed consent, reduce the patient's fear, anxiety, and distress. A sympathetic attitude on the part of the clinician will go a long way towards making the patient feel comfortable. Good communication skills are essential. Patient reassurance at all times is crucial for a successful infusion. Minimize physical discomfort and pain. Ensure the patient's safety is upheld at all times. Maintain consciousness and patient cooperation. Maintain a patent airway. Maintain control of physiological parameters. And return the patient to a state in which a safe discharge is possible. I'm not going to go into the details of informed consent. The purpose of these guidelines is more just about safety and the practice of it. Okay. Before contraindications, one normally gives indications for a drug, but I'm going to leave that up to the psychiatrist, which is going to be presented in another CPD that we hold in the future. So, what are the contraindications to a patient receiving ketamine? Well, a previous allergic reaction to ketamine, a significant side effect to previous ketamine treatment. And then the big ones are cardiovascular, if the patient has unstable angina, a high-risk coronary vascular disease, cardiac failure, arrhythmias, including significant or hereditary QT prolongation. And then psychotic disorders such as schizophrenia or any other delirium or psychosis. Also contraindicated in a personality disturbance that is associated with an inability to participate in a collaborative treatment approach, Remember, I said that we believe in a collaborative team approach in terms of this treatment. And if the person has a personality disorder where they're unwilling to engage, then I'm sorry, the ketamine treatment is not going to help them. Neurological contraindications are increased intracranial pressure from, for example, a tumor or a recent head injury. Ophthalmic are increased intraocular pressure or glaucoma, recent eye injury, porphyria, and pregnancy. Now, we're going to move on to relative contraindications. We require a bit of insight in order to decide whether ketamine will be suitable for this patient. Bipolar affective disorder, a history of psychological trauma associated with significant problematic dissociative experiences, a personality disturbance associated with significant impulsiveness and recurring risks, an unstable eating disorder with significant physical risk factors, current use of a monoamine oxidase inhibitor drug, history of harmful or dependent use of ketamine, and then breastfeeding. It's recommended that patients resume breastfeeding of their ketamine session. So this was a little bit of a point of contention. I thought breastfeeding was actually an absolute contraindication, but it has been discovered that ketamine treatment for women in postpartum depression can be incredibly effective. So we don't want to exclude them from the treatment just because they're breastfeeding. So the literature shows that if they breastfeed 12 hours after the end of their session, there's almost no ketamine in the breast milk. And any ketamine that was given into the breast milk will actually be reabsorbed into the breast during those 12 hours. So it won't affect the baby. Okay. The next part of the guidelines is actually on ketamine pharmacokinetics and pharmacodynamics, but I'm not going to be talking about that today. Our colleagues did a brilliant job of that on the weekend. Thank you so much for that presentation. So let's talk about the ketamine suite. So the staff that are needed would be a doctor, as I've said before, an anaesthetist or trained sedationist. A trained nurse may monitor the patient if the doctor is close at hand. And then roles for the staff, the doctor has a duty to check up on the patient and nurse at regular intervals if she or he himself is not monitoring the patient. If the nurse is monitoring the patient, they must be given blood pressure, oxygen saturation, and parameter ranges that are acceptable and must be given clear instructions on when to call the doctor. The patient's psychotherapist may also attend their ketamine session, and due sensitivity must be given to this relationship by the sedationist or nurse while maintaining adequate monitoring of the patient during the infusion. Safety requirements. Ideally, the ketamine suite should be situated on the ground floor or on a level where there is easy access to emergency services. Emergency telephone numbers should be readily available should there be a need to call for backup medical help or to arrange a referral to hospital. What about equipment? So at minimum, a patient should be monitored with a blood pressure and oxygen saturation. ECG monitoring is optional, although having the capability to monitor ECG in the clinic is, I believe, mandatory. And then a capnograph may be useful for at-risk patients. Your suite should definitely have a defibrillator or AED available, an oxygen source from a cylinder, oxygen concentrator or wall oxygen, an ambu bag or McGill circuit that will connect to your oxygen source, medical suction machine or wall suction, and a set of laryngoscopes and spare sets of batteries. And these should be checked before every infusion that the patient has. Consumables, oxygen nasal cannulae, endotracheal tubes, rigid wire introducer for the endotracheal tube, oropharyngeal airways, suction tubing, Yankauer suction catheter, a kind of adherent tape to secure your ET tube, such as Transport or Sleek, some gauze, and some lubricant jelly. And then onto the drugs. Emergency IV drugs that should be kept in the clinic are adrenaline, succinylcholine kept in the fridge, magnesium, dexamethasone, ondansetron ampules or similar, and Phenergan. And then oral drugs that I keep Ativan sublingual and non-steroidal tablets. For those patients who get incredibly anxious before their infusion, an Ativan tablet sublingual works like a charm. Patient comfort would be a bed or recliner chair, blankets, an eye mask, noise-canceling headphones, and appropriate music. So generally, what is suggested is that you can play instrumental, gentle music. And the music is thought of as the hidden therapist in ketamine infusions. Thus, it's actually incredibly important that you provide music for the patients. They can bring their own music or make their own playlist at home, which can connect to the headphones, or the clinic needs to have their own music that they can play for the patient, which I do. So this is my friend who posed for the photo in my clinic. She's comfortable on the bed, she's warm, she's got a blanket, noise-canceling headphones, block-out eye mask, and she's being monitored, and there's the infusion pump going. The room also should have dimmable lights, ability to darken the room, and it must be a quiet environment. And then, did I say that? Yes, the comfortable room temperature. I truly believe that the room shouldn't be too hot or too cold. The patient must be made completely comfortable. I heard somebody say that they went to one clinic and it was in an upper room of a building and it was just so hot and sticky and uncomfortable in there. So, which will definitely not help with the infusion experience. Okay, let's move on to adverse effects of infusions. Just getting to my notes. There we go. So the mild adverse effects are headache, nausea, and for this reason that I actually give, I keep ondansetron ampules in the clinic, and I give one ampule just before infusing the ketamine, and it is brilliant. The patient doesn't want to throw up. It's not nice to be holding a bucket in your clinic while the patient vomits. Dizziness is also a mild adverse effect. The patient will also get an increase in blood pressure and heart rate, which usually normalizes after the infusion. But this is the issue with people who have those cardiac diagnoses, where this increase in blood pressure and heart rate can actually be a problem, which is why that is a contraindication. The patient can also have increased salivation, that's the effect of ketamine, and the person will feel tired for the remainder of the day following the infusion. And they must definitely not drive themselves home. Severe adverse reactions to ketamine would be an allergic reaction, possibly resulting in anaphylaxis, laryngospasm. Some people can actually become apneic on ketamine. Ketamine produces an increase in respiration generally, which is why it's considered very safe, even for soldiers to give to their wounded comrades. But in a very small group of patients, they can actually become apneic. So it is incredibly important to monitor the saturation and to keep an eye on that. Some patients can develop a rebound suicidality, which affects a small subgroup of recipients, and therefore in your clinic arrangements should be in place for risk recognition and management. For example, emergency phone number shared with a relative, planned telephone follow-up. Then just a note on ketamine abuse. So ketamine abuse, in these cases, they're used in incredibly high doses, for example, upward of 1 gram per dose. So in the clinic, we are giving 0.5 milligrams per kilogram to a patient. So we'd normally start at a dose of about 30 or 35 milligrams, and as we go along, titrate up to maybe 65, 70 milligrams. People who are abusing ketamine are using massive doses, upward of 1 gram, as I said, and more frequently. And this use of ketamine can result in bladder damage, such as hemorrhagic cystitis, and brain damage. As I said, as is written there, these complications should not be seen with the therapeutic doses of ketamine that are recommended in our guideline document. Yeah, so that's all I'm going to share today. Um, there are more details in the guidelines, like there are routes of administration, there's pharmacokinetics, there's treatment protocols for different conditions. I'm not going to go into that this evening. I would like to encourage any of you who are not members of SIPSA to please consider joining SIPSA. If you're involved in ketamine therapy in any way, if you're a psychologist, a social worker, um, uh, a GP, please really join our society. Let's collaborate, let's learn. I have learned so much from being a part of the society. I've learned from the psychiatrists, from the psychologists, and my anesthetic colleagues as well. So please scan that QR code with your phone, and it will take you to our website where you can sign up and become a part of a really awesome collaborative society. Then a few more things we want to tell you about is that we had our SIPSA conference in 2025, but we have been working on the videos and it's going to become an online course. So it's effectively the online conference. It is CPD accredited. So if you are on our mailing list, you will find out about that and we will send you details so that you can watch the videos, answer some questionnaires, and get some more CPDs. Then very exciting. We would love you to save the date for our SIPSA conference next year. That'll be on the 16th and 17th of May at the Vineyard Hotel in Newlands in Cape Town. And we're still working on the program, so that will be announced soon. Right. Thank you.
Wonderful.
Thanks very much.
Kath, thank you for an exceptional presentation and, as always, being a wonderful voice for SIPSA, not only in the content that you present, but in terms of helping everyone feel oriented in terms of the wonderful work that we're all doing, with you being an absolutely instrumental part of it. For those of you who have not yet done so, please be so kind as to put your HPCSA number in the chat just so that we do make sure that you get your CPD points. And with that said, we are now going to move on to a talk by a lovely clinical psychologist, Leisha Davies. She's been working in the field of mental health for more than 15 years, providing support to individuals suffering from mental distress. She practices in South Africa and the United Kingdom. Her primary treatment modality is schema therapy integrated with psychodynamic psychology, trauma-informed somatic practice, transpersonal psychology, and mindfulness. She's also completed a 14-month in-depth psychedelic practitioner training program in 2021 with the Synthesis Institute in the Netherlands. In 2023, she undertook brief training in ketamine-assisted psychotherapy with Dr. Phil Wolpson, a leading specialist in this emerging field for mental health treatment. Alongside her general practice, she currently offers ketamine-assisted psychotherapy for treatment-resistant depression and some other mental health conditions. She also has an abiding interest in conscious breathwork to support optimal mental health and is a certified breathwork practitioner. So I think we're incredibly privileged to be learning from you this evening, Leisha. She will be presenting to us ways of navigating the ethical and clinical dimensions of this all too nebulous concept of holding space in ketamine-assisted psychotherapy. Leisha, over to you.
Thank you, Anthony, and thank you, Catherine, and lovely to be here with all my colleagues. So let me share my screen. Let's just go share and bring up my presentation. Let's go slideshow. How are we doing? Can you see?
Perfect.
Wonderful. Okay. So I was drawn to this topic because it's a phrase that I'm hearing more and more people use. We know that it is used extensively in psychedelic retreat settings, wellness practice settings, and I recently heard a patient of mine express her desire to offer support to a friend of hers when the friend was going through a difficult time. And she said, "I'm going to go and hold space tonight for Susan." So this got me thinking around what is meant when this phrase is used. How do we use it in our clinical work? And so what I offer here this evening is not intended as a prescription of how to do it, but as some kind of thinking about using our own personhood as an instrument when being with others in altered states. I'm going to go through the talk for about 25 minutes or so, and then, as Anthony said, we can share thoughts or open up for questions. The term holding space seems to refer mostly to an aspect of setting. It is something that the practitioner brings to the process. The contemporary use of the term refers to the act and the art of sitting with someone in a non-ordinary state, embodying the qualities of presence, compassion, non-judgment, while the journeyer goes through whatever they are taken by their process. And I want to mention the work of Chara Kalwuthers. She published, it's an unpublished master's dissertation. It's an empirical study on holding space in psychedelic experience. It's a very recent empirical study. And if you're interested, you can hear her talk on YouTube. She spoke at the Breaking Convention conference in August this year. So, holding space is also a spatial concept, bringing to mind a container.
Recording in progress. I will ask them as soon as I can.
That comprises two parts. So holding is the outer edge of the boundary, and space is an open field where the practitioner is invited to let go of rigid identities, attachments, fixed perceptions, and even cherished theories, at least in those moments, so that the participant's experience can move through them more freely. And the alchemy occurs within this container that needs both boundary and space. So when thinking critically about this concept, I turned to my own field, psychology, to inquire. And I think the concept can be linked to two forefathers in psychoanalysis from the 1940s and 50s, who wrote extensively on the holding function, this is Donald Winnicott, and the containing function, Wilfred Bion. The concept also has its roots in indigenous practices, but we don't have time to go into that this evening. So Winnicott viewed holding as a foundational experience in psychological development. His concept of holding refers to the physical and psychological care a mother provides to her infant, creating a nurturing environment that allows the child to feel safe, secure, and integrated. This includes the mother adapting to the baby's needs, protecting them from overwhelming frustration, and offering a consistent, reliable presence. In practice, the practitioner creates a holding environment that fosters a sense of solidity and personal growth where patients can process and manage their difficulties. This is a receptive, listening presence where the personhood of the mother is in the background and supports the baby to explore and discover himself. I draw on Bion because he's the originator of the term container contained, at least in psychoanalysis. So what is meant by this? Well, for Bion, the container is a person, often the mother or the analyst, and by mother I mean caregiver, who provides emotional and mental containment for the overwhelming, unformed emotions of the child or the distressed patient who is the contained. The container, mother or therapist, digests or takes in these raw emotions, does not get reactive, and then transforms them into something understandable and manageable. This content is then returned to the patient in a form, perhaps an interpretation, perhaps an elaboration or a metaphor that can be processed and eventually internalized to develop the patient's own capacity to both feel and think about their emotions. The container-contained concept is thus more active than the holding function of Winnicott. And I believe both have a place in psychedelic therapy, although much is touted about non-directedness in psychedelic therapy. Then a forefather who is more recent to contemporary psychedelic work, Stan Grof, even though he didn't use the term holding space explicitly. Now, Grof facilitated over 4,000 LSD therapy sessions in the 1950s to the 1970s. And in his framework, holding space involves allowing deep emotional catharsis without interference or premature interpretation. So here, his idea is more akin to Winnicott's. Trusting the inner healing intelligence of the person undergoing the experience rather than the practitioner taking the expert position. Creating a safe and contained environment, especially needed in altered states. Environment here refers to aspects of both the physical environment and the emotional presence of the practitioner. Being grounded and present, even in the face of intense or chaotic experiences. Now, this sounds somewhat like Bion, who speaks about the practitioner taking in the raw, intense affect of the patient, sitting with it, metabolizing it, and then returning it in digestible form. I see this a little bit like the mommy bird, feeding the baby bird from food that she has taken in, processed, and then regurgitated, until baby bird is able to do this on their own. It may sound patronizing, but for people in fragmented states of mind, this can be incredibly supportive and grounding. So the work of Winnicott, Bion, and Grof provide us with some theoretical basis for the concept of holding space. But how does it look in practice? So in practice, holding space might look like sitting quietly beside someone as they cry or process deep insights, keeping calm during a person's emotional, somatic, or visionary breakthrough, reminding someone to breathe or grounding them gently if they feel overwhelmed, providing a peaceful, private environment where someone can go inward. In my psychedelic practitioner training, we spent 2 8-hour practical days in the art of holding space. The experienced facilitators, of which there were 8 for a group of 20 participants, had 10 of us trainees sit against the back wall of the circular group space to observe in silence. We needed to show up with full mindfulness to what was emerging emotionally and somatically in our own bodies, hearts, and minds as we witnessed the big transformational collective energy unfolding in that space. We were taught how to glide out of the room if we needed the loo during the 6 to 8 hour process with minimal disturbance and absolute calm. Thankfully, I'd had enough experience by then of sitting in stillness, or I think I would have died. This act of witnessing still ranks as one of the most powerful and rewarding experiences of my life, and I hadn't even taken the psilocybin. So in spite of this very expensive and thorough training, I'm afraid to say that there are times when I have messed up. And I'll share the following vignettes to demonstrate just how easy it is to slip into a not holding space, especially when in a clinic environment rather than a retreat setting where often there is the immersion in an expanded sense of time and a greater emphasis on ritual and ceremony. A clinic runs on a tight schedule. I was supporting a patient in a ketamine journey in the presence of the medical practitioner. As my patient was coming out of the trip, the doctor and I started to discuss when her next maintenance would be. There was an unacknowledged anxiety between us as we are both really busy and urgently needed to get the next arrangements in the bag. The patient quite rightly called me out on that afterwards. I had too quickly shifted from holding space in the non-ordinary realm to the ordinary of diary management. It came from a good place to button down time in our busy schedules for this patient, but well, at the wrong time, and a failure of holding. Fortunately, the patient and I had a solid therapeutic relationship, so we could repair this rupture. Holding space starts inside ourselves, even before the very first encounter with the patient in the therapy space, and until the very last contact. And this is easier than it sounds. On a different occasion, I recall waiting for a session with my patient at a ketamine clinic, and the doctor came out to apologize as his prior patient had had a difficult experience and needed extra time. My patient was stressing by being kept waiting, and I was beginning to stress too. And I could see how this dedicated, committed doctor was working hard to keep calm in this dilemma of his current patient in the room while the next patient was anxiously waiting. In practice, equanimity is not always easy. It is often the smallest of gestures that makes a difference. When the patient crosses the threshold into the treatment space, that's the time when ordinary reality needs to be suspended, and the respective practitioners need to shift with that. All of them. That's the nurse, the sedationist, the space holder, and so on. The tension here was around time. Patients are often very sensitive to being rushed. Different people may need more time, more spaciousness, yet we as practitioners need to watch the clock. I wanted to get on with the business, and the patient needed me to join her in her timelessness. I mention these incidents not to criticize, rather to be mindful, as the more of these sessions we do in a week, the greater the risk they become routine for us. For each patient, each session is a new prospect for healing. So who is equipped to hold space? Here I refer to Janice Phelps's 2017 paper entitled Developing Guidelines and Competencies for the Training of Psychedelic Therapists. She articulates a number of core competencies required to be a psychedelic practitioner that can be from any discipline: an anaesthetist, a medical doctor, an arts therapist, psychiatrist, psychologist, etc. This is an over and above set of competencies for psychedelic work, irrespective of registered professional specialty. She identifies 6 core competencies, and I'd like to touch on 4 as they are relevant to the concept of holding space. Empathic, abiding presence. The term abiding refers to the capacity to witness the mystery of life in action during psychedelic therapy. Components include composure, evenly suspended attention, mindfulness, empathic listening, doing by non-doing, responding to distress with calm and equanimity. This is quite a big ask. This is important because patients, when in altered states, are very susceptible to mood and voice tone of the practitioner, the nurse, and other people in the unit. Some of the patient's feelings towards the treatment team may be a projection or transference rather than reality-based. For example, one patient of mine became acutely sensitive in the altered state to the expressions on the faces of those in the room with her. She had been for several ketamine sessions with me and with the same medic present. She had a history of relational trauma, including difficult relationships with a string of medical doctors. A few days before a treatment session, she started to question whether the medical doctor had something against her, and she said the doctor's expression when looking at her was cold and rejecting during a prior ketamine session. She said she was feeling unsafe in the treatment team. I encouraged her to contact the medic directly in advance of the next treatment day, and this attuned medic responded sensitively and non-defensively, and the patient was deeply reassured. This example highlights how ordinary feelings and dynamics can be amplified in altered states, and these features may only emerge days or weeks after a session and could affect future sessions unless dealt with empathically. Trust enhancement as a core competency. Phelps discusses enhancing trust in 3 areas: the patient's view of the practitioner as a trustworthy guide, the participant's trust in their own inner healing capacity, and the practitioner's ability to reliably normalize for the patient that paradoxically, transformation can arrive in unexpected ways. And so to expect the unexpected is a normal part of the process. This is often hard for people with a high need for control, often rooted in trauma. Another aspect of trust is for the practitioner to be knowledgeable about the types of subjective states that patients may experience and adroitly convey normalization of these during preparation. After all, if you're going to climb Mount Everest, you will want an experienced guide who knows the terrain really well. Therapist self-awareness and ethical integrity. A small point, but a big subject. Phelps refers to the value of the practitioner being very aware of the power differential in altered states. Patients are hyper-vulnerable when in these states, and the practitioner is not, or at least not in the same way. The cultivation of ongoing self-reflection is important, especially when the practitioner's own shadow dimensions, such as excessive ego or being attached to a positive outcome, that's a difficult one, might emerge. Ethical conduct is even more imperative when working with non-ordinary states. You may know the work of Kylea Taylor, who writes specifically about ethical practice for non-ordinary states. This is over and beyond our standard ethical codes. Spiritual intelligence refers to a quality that goes beyond the conventional medical treatment paradigm. It implies awareness of a relationship to the transcendent or transpersonal, transcendence of the small self, to the universe, to the value of accessing experiences of awe, of wonder, an acceptance of change and impermanence, and the experience of love. The patient was referred to me for preparation and then for integration prior to a ketamine process. She'd had a difficult history with the Catholic Church, but when we spoke of that, she said she still had her rosary as it gave her great comfort. I suggested she take it in with her. She duly did so and had a vision of a beautiful temple. She said it was not a church, but clearly a spiritual space imbued with qualities of beauty and peace and forgiveness. She saw Jesus coming towards her and offering her unconditional acceptance, something she'd not had in her life. This was her first positive spiritual experience in years, and I really leveraged that in the integration, as I could see it opened a window towards a potential resource of richness to counter the barrenness of her depression. I'm so glad that Phelps mentions love, as I think it is a central aspect of this kind of transformational medicine, and it isn't spoken about enough. She mentions it explicitly, although I do think it is implicit in the theories and practices of Winnicott, Bion, and Groff. So, in summary, the literature defines the key aspects of holding space in psychedelic work as non-interference. The space holder doesn't try to fix, analyze, or over-direct the journey. Instead, they trust the process and allow it to unfold naturally. Now, I have one reservation with regard to the non-directiveness, and that relates to if shadow material emerges, such as spiritual narcissism. So if someone, for example, believes that they are now imbued with special gifts to show others the way, I advocate here for an intervention from the practitioner, and this is why psychological integration may be important. Emotional safety. The person feels safe enough to face difficult emotions, memories, or revelations, knowing that they are not being judged or rushed. They are being held in deep reverence. Grounded presence. The space holder remains calm, centered, and emotionally regulated, even if the journeyer is going through turbulence. This anchors the space and the experience. Compassionate support. They may offer gentle words, physical reassurance like holding a hand with consent, or just quiet presence. It is about being with, not doing for. Physical safety and practical care. This includes ensuring the person is in a safe, comfortable environment and has their basic needs met, like water, blankets, and so on. And respect for the journeyer's autonomy, even in difficult moments. The facilitator avoids imposing interpretations or steering the experience. They support self-discovery. So holding space in psychedelic contexts is important because psychedelic experiences can bring up deep trauma, spiritual insights, ego dissolution, or existential challenges and or revelations. Holding space allows these to emerge without suppression or distraction, making integration and healing more possible afterwards. And I want to conclude by reading a poem called Holding Space by Rionach Aiken. I see you, soulful one. I'm just holding space, you say, as if you're not really doing anything. I see you, touching the shame, the pain, the fear, digging the foundations of your loving presence deeper and wider. I see you, willing to hold the world in your hands, not looking away from the darkness, not pretending to understand. I see you stretching beyond easy answers, the mind shutting rights and wrongs. I see you stumbling on shaky legs after uprooting the old ways, fumbling through the unknown to find a truer home. I see your soul surfacing, sharing its tender wisdom in the space you've washed clear with your own tears. I see your devotion to your own unfolding, the years of practice so you can just hold space. As a ballerina just dances, as a soprano just sings, as a maestro just plays. I see you embracing it all so you can just hold space for love. Thank you all.
Leisha, thank you for an exquisite presentation. Thomas Huxley often refers to the slaying of a beautiful hypothesis with an ugly fact, but you have given us something very, very different. I think you just offered us a very poetic realization of a beautiful concept. So thank you. That was a pleasure to listen to. And I'm sure I speak for all of the psychologists when I say that I think that while Jung has often been at the forefront of discussions around psychedelics, it's a great pleasure to hear the middle school and object relations get its due. And I think you did that so seamlessly and so beautifully. So thank you. Everybody, we now can open up the floor for questions and comments. You're very, very welcome either to raise your hand and unmute yourself, or if you prefer to put a question in the chat, I'm happy to pose it to either of our speakers. So we know you didn't just come here to listen, you also came here to speak, so please let us know any questions, any thoughts. The good news is the chat is simply filling with lots of compliments for you both, so that's a great start. I see a hand. Mike Henry. Mike, please give us your question.
I'd just like to make a comment. I sort of discovered this world of psychedelics about 3 years ago, and I've done a lot of reading and research, and we've run a little clinic for the last 3 years in my general practice back in Port Elizabeth. And I've become aware that it's a niche of medicine that's kind of different from anything else we've ever known or practiced. And I watch with a mixture of annoyance and anger when I see turf war between who owns what space and medical aids, and whether it should be done in an ICU or it should be done in a different setting. And listening to these two talks this evening has just cemented my idea that this is a very unique situation, offering ketamine-assisted therapy to people. And it just makes irrelevant a lot of the noise and the nonsense and the debate that we hear around who funds what and who pays for what and who's allowed to do this and that. So it's more of a comment, and I just want to thank both speakers for highlighting what it's really about. That's the end of my comment. Thank you.
Thank you, Mike. Wise words. Philip, I see your hand is up.
Hi, Leisha, that was lovely. That was so good. I've been waiting for that talk for weeks. I'm going to ask you to put your head on the block and give a call on what you think the ideal session length is for a ketamine. Whether it's just, like just a plain infusion somewhere, or even in like, in an office, a doctor's office, or ketamine, that's got a therapist there to do the assisting. I have my opinions, but I'm keen to know what yours are.
I think it's a difficult one, and it's I think it's about sort of trying to balance the pragmatics with also what patients need, and I think different patients need different things. So, I've been with people where 45 minutes to an hour really is enough, and then I've been with people where they need 2 hours. And so, how do you manage a busy diary and be able to reach as many people as you can? And I don't know what the answer is. Ideally, if it is, again, we've got to look at overheads. People are paying for premises, etc. But perhaps if there's a holding space, if there's a garden or a recovery room or something like that, where if you've got some people who maybe need a little bit more time, but it's how you make that work in practice, I think is really hard. So, yep, you say you have some ideas. I'd love to hear them.
No, no, it's yeah, I think, as you say, there will be some people who will trot in and trot out. And I guess you don't even know. Some clients you might be able to call, but you might still be wrong, and they might have a session which surprises everyone, and they need that extra time. Yeah, and it's just such a golden period. And so for you, for one of us to say, "Oh, I've got another person,"
Yeah.
the missed opportunity.
I think also one of the things that sort of bothers me a little bit, and again, I don't know how to solve it, but at what point does holding space end? So, a lot of my clients go home in an Uber. I don't know if I want people to go home in an Uber.
No.
And people with relational trauma often don't have big social circles. They've got all these fractured relationships. So, I think these are just some of the dilemmas around where are the edges, where are the boundaries of what we do, how do we help people in that extended phase also be safe? And I think that's what's so special about our group, is maybe that's a whole conversation in itself one day.
Yep. Definitely.
Yeah, it's quite a it can be tricky. I mean, I have in my clinic sometimes had 3 patients booked. I've got 2 treatment rooms, so I can start one and then let my nurse sit with her, and then I will go into the other room and do the other patient and pop back and forth and check on both of them. And then there might be someone else. Unfortunately, if the previous one's not finished, then that someone else is just going to have to sit on the comfortable couch and wait. Yeah, I've trained 2 GPs to assist in my clinic as well. And what's incredibly important is not rushing the end. When the infusion ends, you turn the pump off, and these pumps have a terrible habit of making an incredibly loud noise as soon as the infusion is finished. So I've tried to switch it off. I can't. Chinese brand. Anyway, so we try and switch that noise off, and then leave the patient for 10 minutes. Continue monitoring. I've got my monitor beeps on silent, but we watch the monitor. And after 10 minutes, only then tap on the shoulder. How are you? Are you okay? I'm going to take the IV out now. And some patients as well, they want a slower infusion. So normally I run it at 30 mils per hour, but some people I run it at 20, 25 mils per hour, just because, yeah, it just works better for them. So we can individualize, and it doesn't all have to go according to schedule. Just another thing I wanted to say, sorry, Shannon, I see you've raised your hand. On the talk on the weekend from Anthony and team, it was said that the treatment room should ideally be in nature. And I'm sure we would all love to have a treatment room in nature, surrounded by plants and garden and a forest and all of that. But I really think that we can make our treatment rooms in nature. We can bring plants into the room. So my room has no windows, and Anthony mentioned that I have children, dogs, and cats. I cannot care for plants. Plants die. At least I can keep the animals alive. But yeah, you can put fake plants in the room just to add to the aesthetic of it, just to make it more homely. My waiting room looks very homely. It looks like a vintage lounge. I think Philippa saw it once. Yeah, so we don't have to be super clinical all the time. I definitely believe that we need to have the safety in place, the monitors, turn the beeps off, have the stand behind a plant or whatever. You can shield it, you can make it look homely and comfortable, add some plants, and that can all help with the experience.
Shannon, if you won't mind, I just wanted to build on what everyone has mentioned thus far, and I wanted to say, both in terms of what you mentioned, Leisha, as well as you, Mike, about not only the importance of holding space, but also the dissolution of boundaries. I think it's particularly valuable, Leisha, that this was a talk both for psychologists and medical doctors. Because at least at our center, what we found has been tremendously important is there are some occasions where a patient has gone through a particularly profound experience, needed that extra time, and the person who has been most instrumental at times in holding space has actually been our GP. And she's done a remarkable job with great care and great thought in providing a safe, abiding presence, and done more therapeutic good than I think she often recognizes. And so I think what you'd offered us is really, really valuable, because this is across the board for all of us. You don't have to be the therapist to be holding the space. So I'm really, really glad that you could echo that for us. But I think, Kath, as much as you say, I think you might not have kept the plants alive, but by the looks of your background, I think you've got the aesthetics down. You're going to be fine on this. Shannon, you've been very patiently waiting. We'd love to hear what's on your mind.
Thank you very much. And I was going to say, Catherine, any advice to somebody who used to be a plant killer? Orchids are pretty good, I've discovered. And Ruth Stewart, my very close friend and colleague here in Port Elizabeth, gave me the insight into why I seem to be able to keep orchids alive is because they thrive on neglect. You only need to give so that might be my try much. And I'm glad to see Dr. is here because I'm hoping that he's going to be assisting me a lot more in the future because I'm very new to this field, but very excited to start my journey with hopefully assisting some of my patients with the ketamine process. But I think my question now is really more with regards to a slight problem that I'm experiencing at the moment. And then when Leisha, when you mentioned fractured relationships, the issue I have at the moment is a client who has treatment-resistant depression. I've worked with her for many years, and absolutely a lot of trauma, but trauma is not the issue. She doesn't have symptoms of PTSD. Her issue is her depression, and the struggle that I have at the moment is the psychiatrist that's recently taken over her care is a close colleague of mine and someone who I've had a really good collegial relationship with. Um, but when the client came to see me, we'd stopped therapy for a while. Her depression again has come back, medication's not helping. So she discussed the ketamine therapy with him, and he was completely against it. So I just wanted to know where do we stand in a situation like that? The GP believes it's a good idea. I believe it's a good idea. Mike, I'm going to come and chat to you about her. She doesn't meet any of the contraindications. But how do I ensure that I don't fracture this relationship with a colleague that I've worked with for a very long time? That's really the question. And I think what I'm sort of grappling with at the moment, as I haven't really even started this journey, and I'm sure I'm going to come up against this from time to time.
I
So
mean,
that's to whoever.
yeah, anyone chip in here, but I would say just, I think like all conflicts, just good communication and dialogue and recognizing that this is still an emerging field.
Hmm.
And when I started off in this field, I was really scared. My confidence is growing. And I think, we are perhaps instrumental in terms of, I suppose, disseminating good ideas, solid stuff as per Catherine's presentation and so on. So, I mean, I think it is difficult when you have elements of the treatment team who are divided. And I think it's really important that there are conversations. And it's difficult because, again, everybody is so busy. And I've certainly found, to find time to get hold of the psychiatrist it's really hard. But I do think that there needs to be conversation and dialogue around understanding differences in position and being able to motivate clearly. I'm so looking forward to that coming talk on indications for ketamine, so that we also feel more empowered around, why are we making this clinical decision? And that comes through just conversation and education. Anyone else have any views? Go for it.
Sindiran, our fearless leader, I see your hand is up. Would you like to comment? You may just want to unmute, Sindira.
I got the unmute button finally. Great. Always when you want to talk, you can't find that unmute. Well, firstly, I want to just thank Catherine and Leisha. I thoroughly enjoyed both your presentations. And the contrasting skill set that both of you bring in is so amazing because just to make a comment before I comment on that last question is that what SIPSA aimed was to bring in people with different skill sets. In the 80s, I was introduced to the therapeutic theme, the therapeutic milieu in psychiatry and the treatment team. We were the first specialty to have a team treating a patient. But, especially when you get to private practice, I wondered what happened to the team. Came 90s and 2000s, I'm now in private, and where's the team gone? SIPSA, as an aim, aims to bring the team back together because in healing a patient, especially something as complicated as mental illnesses, you need a team. You know, they say it takes a village to raise a child. Well, it takes a team to make a patient better. So it's really something that encourages the team, and a reason that we need to learn from the anesthetists, the GPs, the shrinks here, and the psychologists. Look, new treatments are very tricky. The problem with medicine is this concept called clinical opinion. Everybody has an opinion. The problem with medicine is a lot of what we consider is fact is not fact. You know, I was once told these wise words by my one medicine professor who told me 60% of everything I'm teaching you is wrong, but know it anyway for your exams if you want to get a first class pass. And the important, the sad knowledge is a lot of people are endowed with opinions where they believe opinions taught to them are facts. And they really aren't facts. It's like being grounded. A lot of people find it very hard to move away from Newtonian physics to quantum physics, for instance, because they can't conceptualize it. And you have to understand for a lot of psychiatrists and a lot of colleagues, if they weren't taught something during their specialty exams or their undergraduate training, whatever it's being taught or done is taboo. You know, the pharmaceutical industry does a great job in almost try to brainwash you to learn new uh, products, etc. But that's a whole bunch of marketing. To other people, you've also got to understand that some colleagues are fearful because they don't know ketamine. They don't know what ketamine is. They don't know what ketamine does. They're scared because the drug's not indicated. And they still see ketamine from the background of the 70s, where anything psychedelic was declared a drug. And that's highly addictive. Failing to realize we've also been dishing out benzodiazepines, which are probably twice as addictive and twice as druggy, and opioids, which are twice as druggy. And we'll never conceptualize that we're prepared to target the opioid receptors with things that can sedate you and kill you, but we're not prepared to target the opioid receptors with ketamine, which can potentially help you. So, how do you approach this from this dilemma? You've got to understand everybody sees it from a different angle. And you've got to, if possible, have a cup of coffee with them. And if time for a cup of coffee is not there, then try and chat to them, but also listen to them why they don't want you to do it. You know, you should hold space for your colleague that says no. Not holding space literally for them for a journey, but hold space enough to listen to their point of view. The whole concept of holding space is to engage for somebody else and just engage them in the way that they can express their hopes, their feelings, and their fears over it. And also listen to them about what their treatment plan is. So if you don't want ketamine, psychedelics, etc., what is your plan of action? Your plan of action can't be to let the patient suffer. You know, that's not on. We all agree. We took this Hippocratic oath. We're not going to let our patient suffer. So what is your plan of action to make the patient better? So always let them voice their opinions and their plans of action, and then only express your opinion. Never argue your opinion. Just express your opinion why you favoring this. Don't quote literature. Don't quote research. It boggles people down. You know, as a person who does research and quotes literature for a living, it doesn't work. So it's the art of building relationships, the art of the difficult relationship, the art of the difficult conversation. But the more you listen and just give them time and space to express their views, you'd be surprised that even if they say no today, 2 weeks later down the line, when the patient's not responding to their plan A, you become their plan B and just leave space for them to come there. And you've got to understand, people anti-mood stabilizers, people are anti-antipsychotics, they anti everything. And the sadness of our lives is until we are really truly established which the facts are, and we really don't know what the facts are, to be all honesty. And as I reach this stage of my career, the only thing I know for certain is that I know very little, and beyond that, I don't know very much. But until we establish absolute facts and absolute treatments that can make absolutely everything better, everything else we do is opinion. And you have to engage them to listen to what their opinions are. Maybe they've got something right that we've got wrong. Who knows? I hope my 2 cents worth was worth it.
It was indeed. Thank you, Cindy. Mike, you have your hand up.
Yeah, Santran, I think you've expressed it extremely well, and it comes from a vantage point of many years, being one of the early pioneers of psychedelics in South Africa. My comment is this, is that if you look back at the old days of surgery and medicine, it was very paternalistic, and it had to be unlearned. And so we came into the era of informed consent. So if somebody comes in and they've got, for example, a bleeding gastric ulcer, and they're told that the therapy is this, they might say, no, I don't want that therapy. And in the old days, the surgeons would get the huffs and they would walk out and they would want to wash their hands of the patients. And they've had to learn now to reject that paternalistic attitude and find out what the patient would like and see whether it can be accommodated. And I think psychiatry still got to learn that. And with psychedelics, Philippa, my sort of comment would be that if the patient has got a psychiatrist who's very anti, and there are one or two of them in PE, is to raise the question of, would you be willing to have this person get a second opinion, so that it's not paternalistically forced on them that they mustn't have ketamine, and if they do, they now are in the bad books of the psychiatrist. I don't know if I've expressed myself very well there.
No, you have, Mike. Thank you. And I think we've all built on that point really nicely. And Shannon, I saw you mentioned in the chat you're grateful for the contributions everybody has made. With that, we are very grateful for all of you taking some time this evening to join us for what I think were both exceptionally useful and enlightening presentations. Again, Kath and Leisha, thank you both so much for the time and energy you have given us. You have given us so much food for thought. We hope everybody has a lovely evening further, and we look forward to seeing you all again soon for our next event. In the meantime, have a wonderful start to the week, everybody.